Some, I think, objectives that we're looking for the completion of today's presentation. Just review how hand grip strength and strength capacity might be connected with mobility as a whole. Presenting potentially, if you're not aware of what hand grip strength is, maybe how to measure it. And potentially this with some references from the literature, maybe provide some encouragement for the inclusion of hand grip strength in maybe healthcare settings, maybe in educational settings, as appropriate for maybe the setting in which you're joining today. So the older adult demographic is rapidly growing, both locally in the United States and globally. Specifically, I've seen some statistics that suggest that the older adult demographic is projected to increase by maybe 113% by the year 2030. And then similarly, too, as you've probably seen on the pre-questionnaire, that for the first time in the United States, the proportion of older adults is projected to outnumber the proportion of children by the year 2034 for the first time. And with this rapidly growing older adult demographic comes a lot of, I think, unique healthcare challenges to help address the unique healthcare needs of the older adult demographic. And with that, there's a lot of, I think, strategies and opportunities to help to mitigate those concerns. One of the things that we've been presented on is the need for maybe age-friendly care. And with age-friendly care comes the 4Ms, or just more recently, maybe the 5Ms, that help to, I think, have unique aspects within the need for age-friendly care. For the purposes of today's presentation, we're going to give a little bit more focus on the M of mobility. And how we assess mobility, there's a number of ways in which a person may assess mobility. I think some more familiar assessments may include gait speed, wherein we may be asking individuals to walk comfortably across a short room or across a short course, and then time that assessment for the amount of time it would take for a person to walk comfortably across a distance. Maybe there'd be some balance assessments. Maybe there'd be some other mobility related tasks, such as the timed up and go, wherein we would ask individuals to stand from a chair and then walk to a pre-specified distance and walk back. And a lot of those mobility assessments are within the category of the disabling process of being physical performance. Those physical performance assessments kind of are right in the middle of the disabling process, as kind of the arrow suggests. To the right, which would be the worst possible outcome in the disablement process, might be an activities of daily living limitation. So when you're completing maybe a mobility assessment, such as a gait speed assessment, because that category is closer to maybe an age-related functional limitation, the sensitivity to those tests might be a little bit better, for example, because they're directly assessing mobility with multi-joint movements. But for example, the opportunity to intervene may not be as significant, because when a person maybe has a mobility limitation, the opportunity to intervene and to have maybe change might be a little bit more challenging, rather than if we go to the left, looking at muscle function, which includes strength capacity, might be a little bit further away and might be on the onset of the disabling process, but is projected to be occurring before maybe limitations within a person's mobility, for example. But strength can be a little bit challenging to assess. When I think a little bit about how do we assess strength, some things come to mind. There can be maybe equipment challenges, such that there can be comprehensive strength assessments done in a clinic that may require maybe some large equipment or bulky equipment, and maybe there's budget limitations or space limitations for assessing strength with equipment that just aren't realistic. There could be some educational curves, so sometimes strength assessments may necessitate some complex movements, and not everybody has maybe the background on how to complete those movements. And just thinking about safety too, person's functional mobility, being inclusive. So comprehensive strength assessments can be quite challenging in some regards. So examining feasible solutions to better assess strength capacity, especially in a clinical setting, may have a lot of advantages. And that brings us to hand grip strength. Hand grip strength has been existing in the literature for quite some time. It's probably a little bit more well-known in my experience in the research space relative to maybe the clinical space, where it's maybe a little bit newer. But it's generally regarded as being a convenient and reliable assessment of strength capacity that generalizes to just overall muscle function. And we make that determination because the test, which is oftentimes done on the upper extremities, has a very strong relationship with the strength of the lower extremities. So that's why we're oftentimes able to generalize hand grip strength to overall body strength. Um, it's a pretty simple protocol to use as a whole. So that makes it easy to learn for the administrator, and then likewise easy to learn for a patient or a participant, for example. I also think that it can be done privately. So I think a little bit about the rooming process, and maybe completing a blood pressure measurement within a private room. A strength capacity assessment can likewise be done privately as well. So it doesn't necessarily necessitate an individual to maybe go into a hallway where it's a little bit more public, it's a little bit more high traffic, and then we maybe have collision risk. And then likewise too, maybe individuals may not have the ability to complete a mobility task. The hand grip strength task may be more inclusive. There are some unique exclusion criteria to completing the grip force task, such as maybe having a surgical procedure, severe arthritis, or severe pain that would necessitate maybe exclusion from completing the hand grip strength assessment. But it's generally regarded as being well included for a number of different populations. Because it's been in the research space for quite some time, there's a lot of data that do exist, such that hand grip strength has been included for a number of years, for example, with population-based data such as the Health and Retirement Study, or even more cross-sectionally with the National Health and Nutrition Examination Survey. And with those data, we've been able to do some creative things and make some maybe health inferences such that when hand grip strength is low, it can be linked to a lot of bad stuff in terms of health. Because hand grip strength has been in the research space for quite some time, including in population-based data, we're able to, I think, be creative with some of our data sources that do exist. And we can create variables with hand grip strength and maybe make some determinations with comparisons to peers. Specifically, maybe criteria and reference standards such that we have cut points for making clinically relevant weakness. And there are a number of different cut points that do exist. For example, some of the more popular cut points may include 26 kilograms for males and then 16 kilograms for females. So being below that might be considered as having clinically relevant weakness. There can be some situations where maybe a body dimension measurement can influence strength capacity. So for example, persons that may have more body mass may have higher levels of strength. So we can simply, in some cases, take hand grip strength, which is oftentimes measured in kilograms, and then divided by a body dimension measurement. And those body dimension measurements may include body mass in kilograms or body weight, maybe body mass index, or even just stature, height. So it's kind of like a quotient. But with that comes a little bit more math, and it comes a little bit less interpretability. And then we also need to be a little bit careful about making normalizations as well, such that maybe the relationship between strength capacity and a body size dimension isn't necessarily linear. So we have to be very careful, for example, with persons that maybe have very high body mass or lower body mass, for example, and how that may influence the quotient in making that normalization procedure. And then on the right, too, there are percentiles that exist, so more so a norm reference standard. And we see these and being able to make maybe comparisons to peers that would be maybe specific to age, for example. So examining how maybe hand grip strength is at the 80th percentile relative to maybe the 40th percentile for a person that's at a particular point. So we have categorical variables that do exist. We have continuous variables that do exist for helping to determine the interpretation of strength capacity as a whole. I spoke on an earlier slide about low hand grip strength being associated with a lot of bad stuff, and I'm just going to touch on some of that bad stuff now. Kind of like I suggested before, muscle function, limitations in muscle function precede those in physical performance. So it's not surprising to see that low hand grip strength is associated with gait speed, which is specifically a mobility task. And a lot of the cut points that are specific to an outcome, for example, for determining hand grip strength, such as the 26 for males and the 16 for females that I suggested on the previous slide, those cut points are anchored to gait speed. So it's very clear in the literature that hand grip strength is associated with a slow gait speed. Thinking a little bit about mobility and mobility-related outcomes, because hand grip strength is linked to the disablement process and gait speed, it's likewise associated with falls. And falls oftentimes come with maybe fractures, thinking a little bit about the role of muscle and bone are related. So it's also not surprising to see that low hand grip strength is associated with osteoporosis, for example. Interestingly, thinking a little bit about the neuromuscular system and the systems that maybe have shared processes and how they connect with cognitive functioning, there is literature to suggest that low hand grip strength is associated with Alzheimer's disease related dementias, cognitive impairment. There is some evidence in the literature to suggest that that association is bidirectional, however, but there is nonetheless a signal that does exist. And I've also seen from UK Biobank data that low hand grip strength is actually a top 15 risk factor for early onset dementia. Strength capacity, definitely directly connected to maybe functional limitations, which tends to represent the end stage of the disablement cascade. And low hand grip strength is not just associated with activities of daily living limitations, but they're also associated with each individual task, oftentimes within activities of daily living assessments, and oftentimes to the accumulation of those tasks, as kind of determined here by this colorful diagram, such that we're seeing that low hand grip strength might be influential for helping individuals recover and regain maybe some function after some function is lost. A little bit about clinically relevant health outcomes too, specifically maybe hospital and hospital discharge after admission in persons with greater strength capacity as determined by hand grip strength. Time to discharge after maybe a hospitalization is shorter. The worst health outcome, early all-cause mortality, and even in some regards cause-specific mortality. We are seeing a strong signal that does exist for low hand grip strength on the association for early all-cause mortality. These survival curves do suggest an association that does exist even after matching for clinically relevant covariates that are strongly associated with time to mortality. And so the only thing that's different between these two groups is their weakness status, persons that are weak and persons that are not weak. And we are certainly seeing that persons that are classified as having weakness, their time to mortality is a bit more accelerated. A known study from the literature too, that comes from the Lancet, does suggest that not only is low hand grip strength associated with mortality-related outcomes, but it also might be a stronger predictor of mortality than other popular assessments that are maybe completed in clinical settings, such as blood pressure. But taking into account some of those comparisons, take into account some of those health outcomes and the associations with those health outcomes, there is some literature to suggest that maybe hand grip strength could be regarded as a biomarker of health, specifically for aging, and it might even be a vital sign that is recommended for measurement and review routinely during routine, maybe geriatric healthcare visits. Apart from maybe those clinically relevant health outcomes, we also see hand grip strength included in maybe some hallmark assessments, such as those that might be linked to frailty. So the frailty phenotype, this is a classic frailty phenotype evaluation criteria. Am I back plugged in? I don't know what happened there. All of a sudden, there was a disconnect. I think we should be okay.
We can hear you now.
Okay, I don't know what happened there, and I apologize for any disconnect, but happy to be joining you again. I think I last left off on this slide, which was
But we don't have a picture. We can hear you.
not sure of the technical problems that are going on here, and I apologize for anything on this end that might be occurring that I'm not aware of. But nonetheless, I'll continue. Bringing your attention to the decision algorithm that's on the right side of the slide presentation. We do see low hand grip strength included in the determination of the decision algorithm for sarcopenia. As maybe the assessment phase after completing a questionnaire, that would be a good screener for sarcopenia. And then we also see lower on the diagram severity, where we maybe see a mobility limitation that might be present in the form of maybe physical performance. And there we see maybe gait speed, maybe we see the tug test, or maybe the short physical performance battery. So again, a consistent pattern such that we're seeing strength capacity being examined earlier in the process before maybe a mobility limitation might be present, for example. So we're seeing, I think, an opportunity for strength capacity to be occurring maybe before a mobility limitation might be present. And that enables us, when we see a limitation in maybe low hand grip strength, and the opportunity to improve strength capacity earlier intervention, so that maybe we can address maybe low strength capacity earlier in the disablement process, or maybe earlier in the disease process, for example, to help to preserve strength during the aging process. So the presence of a mobility limitation can be delayed. So early opportunity to intervene when low hand grip strength is present is a nice opportunity before the situation maybe would become worsening. Note that when considering the measurement of hand grip strength, there are non-consistent protocols that do exist. There are some individuals that will use maybe a standing protocol, or maybe take the mean values of multiple trials on each hand, whereas others will maybe take a seated position and then ask individuals to complete a grip force task, and then take the highest performing hand grip strength, regardless of measurement or hand in which it was collected. So there are some inconsistencies in protocols that do exist. There are some, I think, similarities and themes that exist with trying to squeeze the dynamometer with maximal effort, exhaling while squeezing for probably about a couple of seconds before you would examine that measurement. But note that there are some differences that do exist, and that can cause some problems when making maybe comparisons in hand grip strength, or maybe making some comparisons in investigations. So we're working toward, I think, standardization and protocol in the not so distant future, but the current state of the literature may suggest that there are differences in protocols that do exist for measuring hand grip strength. But I'm going to focus on one, and I would suggest that this is a protocol that is very well utilized in my experience, both in research and clinical settings, and that is a seated position. So we're going to ask individuals maybe during the rooming process if we do have a chair that's available for completing hand grip strength assessments, with a backrest and then also arm rest. And we're going to ask individuals to have their feet flat on the floor, back against the backrest, arms on the arms rest, and then kind of, I think, wrists in a neutral position such that the knuckles are vertical and you're almost going to be giving sort of a thumbs up position as a whole. So that's the comfortable position to have individuals engage in for completing a grip force task. And then we would present the dynamometer, and the image of the dynamometer is on the right. And in this regard, we would ask individuals to maybe squeeze the dynamometer with maximal effort, exhaling while squeezing for probably about a second. We would probably explain that protocol, and then maybe adjust the dynamometer to the hand size of each participant, because everybody has different size hands, and the hand grip dynamometer can be uniquely adjusted to be comfortable in the individual's hand. So oftentimes starting on the right hand for consistency purposes, there are some opportunities in research settings where maybe want to consider randomizing that, but maybe in a clinical setting, we're just looking to maybe complete a grip force task beginning on a single hand. So for the purposes of standardization, maybe we start on the right hand. And persons would squeeze the dynamometer with maximal effort, exhaling while squeezing for probably about a couple of seconds with some encouragement too. And it's a nice way to be able to connect with a person and provide maybe some positive emotion and some positive energy in completing the task with some encouragement. And then after that measurement's completed, we would record, and then we would alternate between hands for maybe 2 to 3 trials on each hand. And oftentimes the highest recorded hand grip strength value, regardless of hand in which it was collected, is what's regarded as a person's maximal strength. Now, despite the equipment being relatively low cost and having a very good sustainable energy source such that a hydraulic hand grip dynamometer doesn't require a plug-in, doesn't require a battery, hand grip strength may not necessarily be available to all persons and in all settings. And there can be opportunities to maybe estimate hand grip strength by just having an individual squeeze your hand. Of course, you would have to be well trained in order to estimate strength capacity. And some work that we've done in this location does suggest that persons that have received training on being able to estimate hand grip strength by strategically and gently inserting your hand inside of the participant's hand and asking them to squeeze like a dynamometer, trained individuals can estimate low hand grip strength particularly quite well. So that can be an opportunity to maybe overcome some barriers that may exist with equipment limitations and not having a hand grip dynamometer. Despite strength capacity and low hand grip strength having very good procedural ease and excellent clinical utility, there are some limitations within the protocols that may exist. And maybe we're not examining individual attributes of how the muscle functions more directly, such that we're taking hand grip strength measurements, and that's a measurement of strength capacity, and then we're generalizing that strength capacity measurement to overall how the muscle functions. But there can be some caveats on maybe making that generalization. And within our current hand grip strength protocols, we can maybe look at functional asymmetries that do exist. So if we're recording the highest hand grip strength from a single hand, I think a little bit about what's going on the other side of the body, and that's not being collected or considered. So examining maybe some functional asymmetries by looking at the grip force from both hands and maybe a ratio equation or an absolute percent difference for determining if there's any functional asymmetries that do exist apart from just looking at strength capacity as a whole. And you'll notice on the earlier slide, low hand grip strength, it does have great clinical utility for maybe being associated with a lot of clinically relevant health outcomes. But in some regards, it is its greatest strength, but it's also could be considered its greatest weakness, such that if you're working with a patient that maybe has low hand grip strength, it could be challenging to explain what exactly low hand grip strength is a risk factor for precisely, because we saw outcomes that might be neurological driven. We saw outcomes that are maybe mobility driven. We also can see outcomes that are chronic cardiometabolic. And all those outcomes are uniquely different from one another. So another opportunity for things that would be, I think, presenting itself in the future would be to use maybe more sophisticated technologies and methods apart from those that have been longstanding in the literature and in clinical spaces in some cases. And that's the electronic hand grip dynamometry and accelerometry. And the electronic features enable us to utilize a grip force curve on a monitor. And with that, we can create methods to not just measure strength capacity, but also measure other attributes of muscle function that are more specific. These attributes may include some maximal control, wherein we ask individuals to maintain a grip force task at maybe 25% for a pre-specified amount of time. Maybe we ask individuals to squeeze the dynamometer as hard as they can, as fast as they can for determining rate of force development or explosive strength, which is really strongly associated with maybe mobility outcomes. And in other cases too, we would maybe ask individuals to squeeze a dynamometer as hard as they can, as long as they can, for maybe examining fatigability. And we also use an accelerometer too, and that's that red feature that's placed on top of the black dynamometer for helping to examine maybe contractile steadiness or tremoring that might be occurring during grip force tasks. And some of the evidence that we are suggesting is that evidence is indicating that some of these attributes that are not strength capacity might be more predictive of certain outcomes than others. So, for example, some of the evidence that we're suggesting here does indicate that we're seeing a strong signal that exists for submaximal control being maybe more predictive of cognitive outcomes than maybe hand grip strength, which is already a top 15 predictor of early onset dementia, and then other, I think, recognized outcomes that are linked to cognitive functioning that may include things like education, sleep status, or maybe alcohol consumption. So kind of interesting to see those individual aspects being maybe more closely related with some outcomes than strength capacity alone. So this can be a little bit novel. If you're not familiar with hand grip strength, it can be a novel feature that's oftentimes maybe not well recognized. And I've had the opportunity to maybe work with students, work with healthcare providers, and working with healthcare providers, it can be an opportunity for professional development, for consideration, for implementation into practice. Use in classroom settings, it can be a novel aspect too, such that we can provide opportunities for training and education in classroom settings so that students then, when they phase into their profession, may have some background on how to collect the measurement if they feel like it's relevant to their practice, for example. And there, as I kind of suggested before, there's a lot of evidence to suggest that when hand grip strength is low, as a marker of strength capacity, it's connected with a lot of poor outcomes, and those outcomes are really, I think, tied and integrated and anchored within mobility. Is kind of where we oftentimes see low hand grip strength, and because of that, it could be regarded as an important biomarker that should be routinely collected and maybe monitored for change, or that does occur over time. So examining those assessments earlier, seeing if there's impairments that do exist for earlier opportunities to intervene could be quite important for preserving mobility and preserving strength capacity. As kind of, I think there could be some age-related changes that happens to the muscle over time. Is kind of examined by the two diagrams here. The diagram on the left is kind of a muscle mass and strength trajectory curve. And we oftentimes see maybe muscle mass and strength peak around age 30 or age 40 before those age-related changes kind of factor in, where we see maybe some declines in that regard. And it's interesting to see, too, on the right side that the percentiles that do exist for hand grip strength are oftentimes reflective of maybe those age-related changes that do exist, such that if we see an individual that maybe is earlier in life, maybe at the 40th percentile, maybe we can intervene earlier to elevate their percentile maybe to the 60th percent. So time to maybe age-related and functional limitation could be delayed. So I'll stop here, and I, again, apologize for any technical problems that we experienced, but glad we're able to connect. And I'm happy to answer any questions. I do have my email listed here if you do have any follow-ups that you want to connect with me on during this call or after the call is completed. But yes, thank you for your time, and I'm happy to answer any questions you may have now. I think there's a hand raised.
Yes, hi, this is Mabel. I have a 93-year-old dad, and eventually he did end up falling and breaking his hip, but I'm wondering if something like this, just doing hand grip strength earlier on, I mean, he was getting outpatient OT, PT, but then when that finished, he ended up just having 3 falls, and then the 4th fall, he ended up breaking his hip. But he had weight loss like you were describing. So I'm just thinking maybe he had sarcopenia because there was weight loss, there was frailty, there was weakness, exhaustion. I noticed it declined slowly, but I'm just wondering if something, an assessment like this would have probably prevented or would have caught, the weight, the decline.
Yeah,
and a red flag. Yeah.
it can certainly serve as a screener. We do see it as part of maybe those frailty assessments, as kind of you mentioned, and it's an important screener. Maybe in some cases that may necessitate other assessments or other comprehensive assessments, depending on maybe other evaluations that are performed by a healthcare provider. But it can be a good opportunity to examine strength capacity, and when that might be low. And kind of like I suggested before, there's good evidence in the literature to support that low hand grip strength kind of represents the onset of those subsequent problems that may exist that are related to maybe mobility or sarcopenia or frailty, for example. So using hand grip strength as a screening tool for strength capacity may enable earlier intervention to occur.
Thank you.
There's another question in the chat that's asked what types of exercises are best to help improve hand grip strength.
A good question. That would probably be a great question for a physical therapist, specifically for improving strength capacity. I will suggest, though, that in my experience and examining the literature on this topic is, I guess, speaking a little bit more anecdotally, I have seen some literature suggest that when there are published studies related to low hand grip strength and an outcome, I do see maybe on chats or social media that maybe I would want to begin to squeeze a tennis ball, for example, to improve strength capacity. And I understand that, but squeezing a tennis ball, for example, isn't necessarily going to be reflective of improving strength capacity of the whole body. So we would want to necessarily work on maybe whole body assessments of strength capacity. There is some evidence to suggest that multimodal assessments of physical activity for improving strength capacity might be important for helping to restore strength. And that's just physical activity too. There are other opportunities for helping to restore strength capacity. Maybe those are more nutrition focused as well. So it's important to consider that apart from the physical activity participation. But the multimodal interventions mainly are one thing that I've seen in the literature that may help to restore strength capacity if it's identified as being maybe limited. Okay. Well, if there's more questions that do arise, we can, I think it help to have a conversation about any questions that do exist. Just kind of want to maybe phase into the next part, which would be case examples. So let's just maybe take a look at this particular case, and you're measuring hand grip strength on an older patient that has body mass index classification that's considered normal. Would you consider maybe normalizing hand grip strength to a body size metric? Maybe it'd be stature, maybe it'd be body weight, or maybe just leaving it as a standalone raw hand grip strength measurement. What would you consider, if anything, for a situation such as this? And there can be, again, some, I think, pros and cons to looking at how we can normalize hand grip strength, which is measured in kilograms, to maybe a body size metric, for example. There's body size metrics that do exist, and that creates a little bit of confusion too, such that we've seen hand grip strength be normalized to body weight. We've seen it be normalized to height. We've seen it been normalized to body mass index. All those three things are uniquely different. So which one do you select, for example? How does that maybe impair the interpretability of maybe the hand grip strength assessment? Because when I just measure the raw hand grip strength, for example, it's measured in kilograms of force. Maybe that number is 30, and that can be relatively easily interpreted. So if I take a quotient and create a ratio from that, maybe that interpretability becomes a little bit less. There's also math that's involved. So there's post-processing of data. That's another step. And when we're working in a busy clinic, that can also have unique challenges too. So trying to be thoughtful about maybe what's best for the individual person, what's best for the individual healthcare provider, the setting too, and the amount of time that one may have in order to maybe make some adjustments. I mean, that's probably up to the individual, but maybe consistency over time might be important. Because if we're looking to examine hand grip strength and maybe changes in body composition or stature that might be occurring over time, if we don't have that consistency, then we may have some confusion as to if we're seeing changes in strength capacity, are we seeing changes in maybe body mass, for example, and then also being aware of maybe the tails of maybe body mass and how that might influence the denominator of that equation. So no necessarily like right answer or wrong answer, but I think just making a selection for the opportunity that makes sense for the individual case might be a good opportunity here. Another case example too, we're working with an older adult patient that is considered as categorically weak from those cut points that I kind of suggested earlier with hand grip strength. And just thinking a little bit about how that conversation might go. Maybe an individual is considered as having low hand grip strength. How does that discussion go? How does that clinical conversation go with this patient? And there can be a lot of approaches that can be taken, for example, and maybe the conversation is focused on maybe additional assessments that might help to reveal maybe a condition that might be at the onset, depending on other evaluation criteria that might be taking place. Maybe it's asking a little bit about new nutrition status and caloric intake and protein intake, and is possible referral to nutrition an option for helping to restore strength capacity. Maybe there can be some opportunities too for referral to physical therapy in an effort to help restore strength capacity. So those are the types of conversations that a healthcare provider may have, for example, with a patient that might be identified as having low strength capacity.
We have a response in the chat also that says you could ask how it is affecting their life.
Yeah, that's good. Thinking a little bit about the 4Ms too, or the geriatric 5Ms. That's an important inclusion criteria. Thank you. And thank you for looking at the chat. Not sure if there's any other chat.
There is one more that just came up.
Oh, okay.
It says, I'm going to use a measure that can help both you and I see your hand grip strength and how it relates to overall strength.
Mm-hmm. Yeah, very good. So it can be a new tool to work with. I think that sometimes when introducing this measurement for the first time, it can be a little bit novel. It doesn't move when you squeeze the dynamometer. That's a little bit of a surprising movement because we're expecting it to be flexible, but it's actually quite rigid. And having those conversations about what that experience might be like before introducing the test might be, I think, good for helping patients be comfortable and familiar before the testing does begin, and kind of having a good segue into maybe those clinical conversations as appropriate.